بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. أعزائي طلاب وطالبات كلية الطب، إن شاء الله سوف في الحلقات القادمة نتكلم عن جميع محاضرات الخاصة بالغدد الصماء والسكري. اليوم ستكون محاضرتنا عن لين العظام لدى الأطفال Rickets in children. نبدأ بإذن الله هذه المحاضرة. في البداية I would like to define rickets in children. Rickets is a disease of the growing bones in which defective mineralization occurs in both bones and cartilage of the epiphysis growth plates. It's usually in children associated with bone deformities as well as with short stature, while if there is defective mineralization happened in adulthood, i.e. after closure of the epiphysis, usually is not associated with short stature, usually associated with bone deformity only. When there is defective mineralization happened after closure of epiphysis, the term will not be called rickets, will be called osteomalacia. So rickets in children, osteomalacia in adults. Let's see what's happened for vitamin D metabolism in the body. First of all of us has in the dermis layer of our skin, a substance called 7-dehydrocholesterol. This substance, to be activated, it should be through ultraviolet X-ray from the sun. Ultraviolet rays or X-ray from the sun activates this compound, and this compound will be converted into cholecalciferol. Cholecalciferol has to go to the liver, first of all, to have the process of 25-hydroxylation, where we'll have a 25-hydroxy vitamin D. Then this compound will go into the kidney, where it will be having two types of oxidation. One alpha hydroxylation, and the other one is 24 alpha hydroxylation. By the end of this hydroxylation, we'll have two compounds. One is called 125 dihydroxy vitamin D, which is the most important and most active compound, and the other one is 24-25 dihydroxy vitamin D, which has no clinical significance so far. When we have 125 dihydroxy vitamin D 3, this compound should be reacts with the vitamin D receptors. Vitamin D receptors usually is present in the intestine, in parathyroid gland, in the renal tubules, in the hair follicles. And these receptors are very important for the active compound of vitamin D to have the action. So if we have a problem with a vitamin D itself, or we have a problem with the metabolism of vitamin D, or we have a problem of vitamin D receptors, all these can lead to rickets in children or osteomalacia in adults. Let's see what are the sources of vitamin D. The exogenous source, as we mentioned now before, we have endogenous source from our dermis. What about exogenous sources? Sunlight is the most important exogenous source in the whole world, and we are lucky in Saudi Arabia to have this source in large amount, as we are a sunny country. So we need to get useful from this source. And the other sources, exogenous sources, which are not as good as sun, like we have milk products, fortified milk products, we have a cod liver oil, as well as the egg yolk. What are the types of rickets? The rickets has many types. We have hypocalcemic rickets, we have hypophosphatemic ricket, and we have a combined source of ricket, both of them hypocalcemia and hypophosphatemia. Hypocalcemic ricket is the commonest type all over the world. A large number of children with rickets have a hypocalcemic rickets, while hypophosphatemic ricket is not that common. It's rather a rare type, as well as the combined form of combination of hypocalcemia and hypophosphatemic ricket is also another rare type of rickets. Let's start with the commonest type, which is the hypocalcemic rickets. And this type of ricket associated with high parathyroid hormone, what is called secondary hyperparathyroidism. The causes of this type of hypocalcemic rickets, as mentioned before, lack of vitamin D due to decreased sun exposure, due to decreased intake of vitamin D, due to malabsorption diseases, for example, those with celiac disease, those with cystic fibrosis, those with chronic liver disease, those with biliary atresia, with any GI tract, chronic GI tract problem impairing the absorption of vitamin D. Another important cause, children with chronic liver disease. Why chronic liver disease affecting ricket? As we mentioned in the metabolism, that 25-hydroxylation of cholecalciferol is happened in the liver. So any disease affecting the liver synthesis mechanism will lead to vitamin D deficiency. Another important entity is chronic renal failure and renal tubular acidosis. All are common and important cause of vitamin D deficiency in children. Anticonvulsant, a lot of people doesn't know that anticonvulsant might lead to vitamin D deficiency through the increased metabolism of this vitamin in the cytochrome by inducing cytochrome P450 activity. And the last and not the least cause of hypocalcemic ricket is hereditary rickets. Hereditary rickets is not common in the world, but in Saudi Arabia is rather more common than other parts of the world because we have high rate of consanguinity. And when we talk about hereditary hypocalcemic rickets, we mean either we have a type 1 vitamin D dependent rickets where there is an inherited deficiency of 1-alpha hydroxylase enzyme. So in this type of type 1 vitamin D dependent ricket, will have a normal 25 hydroxyvitamin D, but deficient 125 dihydroxyvitamin D because of the inherited deficiency of the enzyme. While type 2 vitamin D dependent rickets, it happens not because of deficiency of the enzyme, it happens because the resistance of vitamin D receptor, and when we have a resistance of the receptor, the hormone available, 120 dihydroxyvitamin D, will be normal or even high, cannot have its action because the receptor is resistant to this vitamin D and to this hormone. In this case, we'll have a child with severe hypocalcemia and severe manifestation of rickets, and usually it happens in early days or early months of his life, and usually it is autosomal recessive disorder. Among all mentioned causes, nutritional rickets is the commonest cause, and nutritional rickets due to a lack of intake of vitamin D. We have in this country plenty of people not drinking milk. We have in this country plenty of people not exposed to the sun. That's why rickets, nutritional rickets in Saudi Arabia is by far the commonest cause of hypocalcemic ricket, not because we are having not enough nutrition, but because we have a decreased intake of vitamin D from exogenous sources from the food. Another problem of nutrition ricket, or another important cause of nutrition ricket in Saudi Arabia, that most of us are indoor. Our life is indoor, and when we are indoor, whether our children or ourselves, that no sun will be exposed, and sun is very important source of vitamin D. That's why it's better for all of us, our children and ourselves, to have at least 15 to 20 minutes sun exposure per day, and the best time from 10 o'clock in the morning till 3 o'clock afternoon. But when the sun, after 12 o'clock, we want to expose to the sun, please don't expose directly. It should be through a shade. So you sit, or you stand below the shade, and the sun will come from your side, not a direct exposure. Otherwise, we'll have a problem from direct sun exposure. There is also a common practice by our mothers that they keep breastfeeding their children throughout 2 years without any additional food. And as you know, that Al-Quran Kareem ask or allow the mother, the lactating mother, to continue their breastfeeding for 2 years, but from age of 6 months, the mother should introduce solid food containing vitamins, especially vitamin D. So we don't say that mother should not breastfeed till age of 2 years, but we ask them not to be exclusively breastfeeding, i.e. should introduce solid food by age of 6 months. Usually there are two peak of rickets in children. The first peak is through infancy, where this period is having a rapid growth, and also another rapid growth period is during puberty, during changing from a child to adult. This period is also another period where the body needs large amount of nutrition, large amount of vitamins, especially vitamin D. As mentioned, celiac disease, cystic fibrosis, malabsorption syndromes, pancreatic insufficiency, hepatobiliary diseases, drugs, for example, anticonvulsant, are very important to ask in our history about the symptoms of these diseases when we do a systemic review, because they are still important causes of hypocalcemic ricket, but not as important as nutritional deficiency of vitamin D. Another wrong practice we have recently among all our population is eating some sort of diet that prevent the absorption of calcium and iron. For example, eating chapati flour, which is rich in phytate substance. Phytate is impairing the absorption of calcium and iron. This slide showing how Saudi Arabia is a large country and how Saudi Arabia is rich in sun, but unfortunately we don't get use of this sun. We are always inside our house, inside our working places, inside our cars, inside our moods, so we don't get use of the sun, which is the important source of vitamin D. That's why we are having deficiency, most of us, children and adults, having deficiency of vitamin D. And as you can see in this slide, vitamin D deficiency in Saudi Arabia is a common health problem. And usually the susceptible or high risk group are those exclusively breastfed for 2 years, those who have dark skin. Why dark skin? Because the melanin substance present in the dermis prevent the absorption of ultraviolet. That's why those with dark skin should be exposed to the sun more than those with white skin. As I mentioned, white skin people need 15 to 20 minutes per day sun exposure, while dark skin children and adolescent adults need about the double amount, need 30 to 40 minute exposure to the sun. Those with low socioeconomic class will be having rickets because they cannot have or they cannot offer vitamin D fortified formulas or dairy products. Those sitting in the cities, they are more risk than those in the villages. And this is logic because, you know, modernization makes us always inside the doors, indoors, while those in villages, most of their life, they are outdoors. And we mentioned indoors is one of the risk factors for vitamin D deficiency. And to improve our vitamin D status in the body, we have to expose more to the sun. We have to take more dairy products, and we have to educate our children, our families about this problem. Chronic liver disease, mentioned previously, is one of the causes of hypocalcemic ricket because of impaired 25 hydroxylation of cholecalciferol. Chronic renal failure as well can impair 1-alpha hydroxylation of cholecalciferol, which lead to renal rickets, which is the other name of renal rickets is renal osteodystrophy. Renal osteodystrophy is the same thing of renal rickets. Renal tubular acidosis is a common disease affecting children and adults, and in this disease there are two forms: either a generalized form of renal tubular acidosis, where there will be a generalized loss of important substances in the urine, for example, loss of calcium in the urine, loss of phosphate in the urine, loss of protein in the urine, loss of glucose in the urine. And this generalized form of renal tubular acidosis can cause all types of ricket, i.e. can cause hypocalcemic ricket, can cause hypophosphatemic ricket, can cause combined form of ricket, hypocalcemia and hypophosphatemic ricket. That's why very important to understand this disease, and very important to read about this disease for you as medical students, because in this disease we can find a lot of problems, not only rickets. Ricket is one of the problems associated with this disease. Also, renal tubular acidosis could be not generalized, could be only isolated form. A good example of that is isolated hypophosphatemic ricket, inherited as autosomal dominant or sex-linked dominant, and this also a rare disease, but rather we have to understand and read about this disease. So as I mentioned in previous slide, that hereditary rickets could be a hypophosphatemic ricket, which is because of isolated renal absorption defect, renal tubular acidosis, or due to vitamin D dependent rickets due to type 1 absence or congenital deficiency of 1-alpha hydroxylase enzyme, or type 2 vitamin D receptor resistance ricket. Type 1 and type 2, both of them are autosomal recessive disorders. Type 1, lack of 1-alpha hydroxylase enzyme congenitally, and usual presentation is early rickets, clinical and biochemical early rickets. And to differentiate inherited from non-inherited rickets, usually inherited rickets happen in the first 6 months of life, while non-inherited rickets usually happen after 6 months of life. Type 2, vitamin D dependent ricket, also autosomal recessive disorder, but here 1-alpha hydroxylase enzyme is usually normal, and the problem from the calcitriol. Calcitriol is the name of 125 dihydroxyvitamin D. So calcitriol receptor resistance. Calcitriol receptor resistance. This type common in Arabs, Yemeni, Saudi Arabia are most affected Arabs of this type. And in this type, very important that some of these children, they don't have hair. They have alopecia, baldness. And the alopecia here, usually alopecia totalis. So in addition to clinical manifestation of rickets, there is alopecia totalis. And in this type, the usually hypocalcemia is severe, and clinically bone deformities are severe, and the affected children, they suffer from manifestation of hypocalcemia. And very important message for this type 2 vitamin D dependent rickets, that it is very hard to treat, very difficult to treat. Why? Because the receptor is resistant. Hypophosphatemic rickets, as I mentioned before, is one of the types of ricket, but it is not common rickets, rare type of rickets, but it is present, and we should be aware of this type. But in this type, there is no secondary compensation from parathyroid hormone. So in hypocalcemic ricket, there is secondary hyperparathyroidism, while in hypophosphatemic ricket, there is no compensation. So there is no hyperparathyroidism. Parathyroid hormone here is usually normal. What are the causes of hypocalcemic ricket? Also, nutritional phosphate deficiency is common. Prematurity is another common disease associated with hypophosphatemic ricket. Decreased intestinal absorption of phosphate, especially those taking antacid. Why antacid? Because antacid containing aluminum hydroxide, and aluminum hydroxide impair absorption of phosphate from GIT. Also, renal tubular acidosis, proximal type, one of the important causes of hypophosphatemic ricket. Vitamin D resistant ricket, which is autosomal dominant or sex-linked dominant disorder, affecting the renal tubules absorption of phosphate, and another rare cause, but is one of the causes. Tumor, cancer, oncology can lead to something called oncogenic stimulation. So there is phosphate loss in the urine because increased substance called parathyroid hormone related peptide produced from the cancer cells itself, parathyroid hormone related peptide that increase in the cancer, that will lead to increased urinary loss of phosphate, and that will lead to hypophosphatemic ricket. And last but not the least cause of hypocalcemic ricket is hereditary autosomal dominant form or sex-linked dominant form, which is a rare cause but is present. We have many patients of this disorder, and usually in hereditary hypophosphatemic ricket, males affected more than the females. The prevalence of this disease is 1 into 25,000 children. Phosphate usually lost by the renal tubules, where we have low phosphate and normal calcium, normal serum calcium, and the vitamin D will be normal or low. 125 dihydroxyvitamin D will be low or normal. And usually this type of ricket is severe, hereditary ricket is severe and associated with short stature. Congenital rickets, another common problem. Why it happens? Usually due to deficiency of vitamin D from the mother. So if the mother during pregnancy is not taking enough supplement from vitamin D, also she will have, during pregnancy, she will have vitamin D deficiency, and here fetus will not have enough vitamin D during gestation, so the child will have, or the baby will have, in the first 6 months of life, especially the first 3 months of life, low vitamin D, which lead to hypocalcemia. And the hypocalcemia, sometimes the child present, or the baby present in the emergency room with the seizure, with tetany, with other manifestation of hypocalcemia. That's why we usually ask the mother to take prophylactic vitamin D supplementation during her pregnancy, as well if she's lactating after delivery. If she wants to lactate, also she should be on prophylactic vitamin D, and the prophylaxis of vitamin D, the dose is from 500 to 1,000 units per day. But if the mother is deficient, she should take from 2,000 to 5,000 international units of vitamin D per day. Now we'll speak about the skeletal manifestation of rickets. And before we look into the slide, does anybody knows about what will be the clinical or skeletal manifestation of a child with ricket? Can anyone of you tell me what are the clinical manifestation of rickets? Usually we start from the face. We have to examine the child from the head to the toe, and the first from the head we have to examine the fontanelle. Fontanelle is very important to be measured or to be examined in the rickets. Usually rickets associated with delayed closure of anterior and posterior fontanelle, especially anterior fontanelle, and those with open anterior fontanelle, usually it is widely opened. So anterior fontanelle either widely opened or delayed closure of anterior fontanelle is one of the common manifestation of rickets. Another common presentation of ricket is something called craniotabes. Craniotabes is when we press onto the skull, we feel it that soft bones. We feel the bones are soft. What is called craniotabes. Craniotabes. Third thing, the child with ricket usually have delayed eruption of the primary teeth, and we have enamel defect of the teeth. So either enamel defect, delayed eruption of the teeth, frontal and parietal bossing, and the shape of the head will be something called box-like head. Then we go down from the head into the extremities, where we'll find enlargement of the wrist and the ankle. The bone will be widening of the wrist joint and the ankle joint because of defective mineralization. The legs, when we look into the legs, either we have a bow legs or knock-knee legs, and usually what is called coxa, and valgus deformity. Also, we could have green stick fractures. Also, we could have deformities of the spine, bell face, legs, and short stature. And bone deformity is important to look. This slide is very important. And if you can see by this mouse, that the head that we examine for the sutures, we examine the anterior fontanelle, we examine for the head, the craniotabes. Fontanelle is either widely opened or delayed closure. The frontal bossing, you can see frontal bossing. You can see also rachitic rosary. The rachitic rosary is the enlargement of costochondral junction. We have Harrison sulcus. Harrison sulcus is happened because the costal bones is weak, so the muscle diaphragm is a muscle that contract the costal ribs inside the body. So we'll have a Harrison sulcus as well. We'll have a wide joint at the elbow and the wrist. We'll have a distended abdomen. Why distended abdomen? Why distended abdomen? Yes, because the muscles will be hypotonic. Why muscle will be hypotonic, abdominal muscle? Yes, because of hypocalcemia. So hypocalcemia lead to hypotonia in the muscles, and the hypotonia in the muscle lead to abdominal distension in children with rickets. Now we comes into the lower limbs. There are wide joint and wide bones at the femur, at the tibia, at the fibula, as well as you can see, bowing of these bones. There are some extra skeletal manifestation of ricket as well, not only skeletal deformities. We have a seizure and tetany due to hypocalcemia. We could have generalized body hypotonia. We could have a delayed motor development. When you ask about the developmental history, you'll find a delayed motor development. We might have the waddling gait, the child with ricket when walks with a waddling gait, fatigue, muscle pain, body aches, all are common manifestation of vitamin D deficiency, especially in adults. It's feeling that always fatigue when the walks, feeling pain in the muscles and the bones, also another important extra skeletal manifestation. And the child also, during examination of the child with rickets, we should examine for other skeletal manifestation. For example, if this child having hepatic rickets, so we have to examine the liver. If this child having, for example, anticonvulsant, so we have to examine the CNS manifestation. Sometimes we examine the child with rickets or vitamin D deficiency, we don't have any features, and that is called asymptomatic rickets. Recent study document that high prevalence of vitamin D deficiency among other systemic disease, not only bone disease. So vitamin D deficiency plays important role in bone disease as well as the systemic disease. Like what systemic disease? They have found that epidemiological studies and new information on the role of vitamin D in preventing autoimmune disease, like type 1 diabetes, like thyroid diseases, autoimmune thyroid disease, as well as cardiovascular diseases, as well as cancer. So vitamin D is not a local problem to the bones only. Yes, it is important, but also to other systemic disease. And usually now a lot of awareness of vitamin D becomes in the media because of these diseases. So now in the last 5 to 10 years, a lot of population, whether children, adolescent, adult, start to screen themselves for vitamin D deficiency and start to take vitamin D supplement because of associated systemic disease. And this is an example. This slide is an example of a child with bowing of the legs, very clear bowing of the legs, and this is knock knee. So can happen bowing. Rickets can lead to bowing, can lead to knock knee. Also, this is another knock knee, and not only knock knee, in addition to, as you can see with this mouse, is a bone deformity. There is severe bone deformity. This child is having hereditary rickets. Why? Because hereditary rickets usually having severe form of deformity. So this child is having a knock knee in addition to severe bone deformity. And this is example or classical example of widening of the bone at the wrist joint, widening of the bone at the wrist joint. This is a Harrison sulcus. Harrison sulcus, and this is rachitic rosary. Rachitic rosary means like habbat al-subha. Rachitic rosary, that means that it's swelling at the costochondral junction, and if you can see it here, it's very clear. Sometimes when it is severe, you can see it by eyes, but other times you have to feel it yourself. And this is another nice slide of rachitic rosary here. And this is also Harrison sulcus. Also the shape, I forget to mention about the shape of the sternum will be deformity, like this child having what is called pigeon chest or pectus carinatum. Pectus carinatum is another manifestation of ricket, and this is here very clear, the chest cage of this child like صدر الحمامة, صدر الدجاجة, pigeon chest. So carinatum, pectus carinatum, and from the side it is in, having Harrison sulcus. Bone deformity, as I mentioned before, frontal bossing, and if you can see this head shape, it is like box-like shape. So box-like shape with frontal bossing. Now we come to biochemical findings of rickets. In biochemical findings of rickets, it depends on the type. Is it hypocalcemic ricket or is it hypophosphatemic ricket? Can somebody tell me about what are biochemical findings in hypocalcemic ricket? Yes, the calcium will be, in hypocalcemic ricket, will be calcium either low or normal calcium level. How come low or normal? In the beginning of the disease will be low calcium, and then when we have a compensatory secondary hyperparathyroidism, we'll have a normal serum calcium. The phosphate is the opposite. Initially in the disease, we'll have a normal phosphate and then low phosphate. Parathyroid hormone in this type, in this hypocalcemic ricket, parathyroid hormone usually is elevated, what is called secondary hyperparathyroidism, to compensate for low calcium. So hyperparathyroidism is compensatory because of low calcium. Hyperparathyroidism will increase renal excretion of phosphate. That's why when we have a secondary hyperparathyroidism, the phosphate level will drop. The alkaline phosphatase will be high in this type. The urinary calcium excretion in this type will be low, and the 25-hydroxy vitamin D in this type will be low. Parathyroid hormone will be high. We come now to biochemical findings of hypophosphatemic rickets. We have the whole time we have low phosphate level, opposite to hypocalcemic ricket. If you remember from previous slide, we have the calcium in the beginning of the disease is low, then normal, but here throughout the disease the phosphate will be low. The calcium throughout the disease will be normal. The parathyroid hormone throughout the disease will be normal, opposite to hypocalcemic ricket. If you remember from previous slide, parathyroid hormone will have high, but here a normal parathyroid hormone level. Alkaline phosphatase here is always high, and vitamin D level will be either 125 dihydroxyvitamin D will be either low or normal. Just a very important message that phosphate is the major stimulus for 1-alpha hydroxylation. What about the radiological manifestation of rickets? By the way, radiological manifestation of ricket doesn't matter. Is it a hypocalcemia, hypophosphatemic ricket, or even a combined ricket? Doesn't matter. All will have these manifestations. So the clinical and radiological manifestation will be the same. The only difference between this type of ricket is biochemical. Radiological, what are the manifestations? Can somebody tell me about the manifestation of rickets? Yes, I will be having generalized osteopenia. Will be having in the X-ray widening of epiphyseal growth plates. We might have fractures of the bone. We might have a green stick fracture, which is called pseudo fracture. We might have a bowing of the bone itself in the X-ray. We might have something called osteitis fibrosa cystica if this ricket is chronic, and there will be a tertiary hyperparathyroidism. And this is very clearly seen: widening, cupping, and fraying. The edge of the epiphysis will be irregular, and the shaft of the bone, as you can see here, the bone density is decreased, what is called osteopenia. So osteopenia, cupping, fraying, widening of the bone, all these are manifestation of ricket. This is very clear seen, widening of the bone at the wrist joint. Here, very clear seeing the bowing of the bones with widening as well. Here, the fractures. If you can see this is a fracture, a real fracture because of rickets. So how to prevent rickets? Who can tell me from previous slides how to prevent rickets? Yes, yes, you are very important. Sun exposure. Sun exposure is very important. And 15 to 30 minutes average from most of the people is enough per day to prevent rickets. So prevention of rickets needs no money at all. It is cheap, nothing, just exposed to sun. But those who cannot expose to the sun, for example, us, we are professional most of the time. You are as a student most of the time in the classroom. We are in the hospital. There's no time to expose, especially as I mentioned before, the best time for exposure from 10 o'clock in the morning till 3 afternoon. So these people, if it's difficulty to expose, we should have dietary supplement of vitamin D. What is the usual dose of prophylaxis? By the way, vitamin D doses depends, is it prophylaxis or is it therapeutic? If it is prophylaxis, we need from 400 to 800 units per day, international units per day. 400 means 4 drops. If you have a drops, 400 means 4 drops. Each one drop is 100. If you want 800, each drop with 100, so 8 drops. From 4 to 8 drops per day. If it is tablet, there are tablets with 1,000 per day, international, so you can take 1,000 units or 1 tablet per day. This is prophylaxis. Different from that, if you have a low vitamin D deficiency or your child has vitamin D deficiency, the dose is different. The dose of deficiency is between 2,000 to 5,000 international unit per day. If the child has vitamin D deficiency, in addition to vitamin D, we need to give calcium if he has hypocalcemic ricket, phosphate if he or she has hypophosphatemic ricket, or both of them, calcium and phosphate in combined ricket, in addition to vitamin D. There are in the market 3 formula of vitamin D. Either a simple vitamin D, what is called vitamin D2 or D3, and this is the best example of using this one is the nutritional rickets, where we don't need to have or to give our child synthetic form of vitamin D, need to give him the raw material, the raw vitamin D, which is very cheap in the market, what is called vitamin D2 or 3. But those with kidney problem, renal ricket, renal tubular acidosis, hypoparathyroidism, we need to give them 1-alpha hydroxyvitamin D. The generic name is 1-alpha. 1-alpha means 1-alpha hydroxyvitamin D3. And those with renal ricket, liver or hepatic ricket, we need to give them calcitriol, which is 125 dihydroxyvitamin D. Lastly, those with vitamin D resistant, as you remember that the receptor is not working, in this type we need to give the child vitamin D, calcium through the central line, intravenous calcium and phosphate through the central line, and they will need it for long period of time because it is hereditary ricket. By this we come to the end of the presentation, but before I finish, just to summarize that if you need to treat, it's different from that. You give prophylaxis treatment from 2,000 to 5,000 and sometimes to 4,000 international units per day, and the duration from 6 to 12 weeks. If you want to give prophylaxis, minimum 400 units to 800 units. Sometimes people, they don't eat or they don't take vitamin D exogenous, they refuse to have it daily. They ask, doctor, I don't want to take it daily. In exceptional status, we can give intramuscular vitamin D injection, and usually it is huge dose. Usually the dose is 200,000 to 300,000 international unit intramuscularly for 2 to 3 months to treat the ricket. But my advice to avoid intramuscular vitamin D injection unless it is highly indicated. Why to avoid? Because many case reports of hypercalcemia and vitamin D intoxication secondary to high dose intramuscular vitamin D injection. I hope by end of this presentation this subject is well understood, because it's very common in our country. Thank you very much, and if you have please any question you can ask me.